Hello and welcome to Our St. Paul, Learn with the League. We present these hour-long programs for our community once a month. I'm Dr. Cheryl Bailey, a recently retired GYN oncologist. I'm also a League board member and a member of the program committee. I'll be moderating tonight's presentation on end-of-life options by our guest speaker, Dr. Rebecca Thomann. Many thanks to the White Bear Lake area and Roseville area leagues for their support of tonight's talk. We'd also like to thank the St. Paul Neighborhood Network for broadcasting and taping tonight's program. You can check our YouTube website and view previous programs anytime. For over 100 years, the League of Women Voters has worked as a citizens league to improve our government and engage all citizens in the decisions affecting our lives. The League is a nonpartisan membership organization dedicated to you, our community. We study issues, we take positions, and we take action. Check out our websites for St. Paul, Minnesota, and the National League to learn more about membership. We'd love for you to give us a try. Let's acknowledge that we're learning today on the ancestral homeland of the Dakota and the current home of Native nations, including the Dakota and Ojibwe. The program tonight is being recorded and broadcast on Facebook Live. So if you're watching there, please put your questions for the speaker in the comment question section. If you're on Zoom, just use the Q&A bubble at the bottom of your screen, and we'll get to as many questions as we can at the end of the talk. Also, we're using the Zoom closed caption feature. These are auto-generated. They might not be exact. Here's a quick look at the election calendar for the year. The primary here in Minnesota is, as you can see, August 9th, and then the general election is November 8th. Please look for candidate forums and voter guides from us. The local leagues will be here to help you make informed voting decisions. So part of the role the League plays in our nation's governance is to tackle complex topics, study and discuss them, and eventually come to accepted policy positions. The Minnesota League does not take a position on medical aid in dying, or the acronym is MAID. This is the point of tonight's presentation. Indeed, the U.S. League does not mention end-of-life options or MAID in its lengthy position on healthcare. Our members and viewers are always hungry for references, and there are any number of books, both nonfiction and memoir, on end-of-life issues. Feel free to use your phone camera to take a picture of this slide, and we'll put this in the chat as well. You'll notice in the left upper corner the different books by Supreme Court Justice Neil Gorsuch. He wrote a rather legal, opinionated book firmly against medical aid in dying. The next title there is Modern Death, How Medicine Changed the End of Life by Dr. Hyder Warwick. And then many of you will recognize the book Being Mortal by Dr. Atul Gawande. It's just a wonderful book for medical and non-medical people on things that modern medicine can and almost more importantly should not do. And then on the right, you'll see three other books. The first one is a memoir called In Love by Amy Bloom. This has just come out a couple weeks ago, very good publicity. Her beloved husband developed early Alzheimer's, and he elected to end his life with a group called Dignitas in Zurich, Switzerland. And as he made that decision, he urged her to write about it, and that's what this memoir is about. And then below that, you'll see the book When My Time Comes by Diane Rehm. She is a journalist, author, and like everyone else now, a podcaster. And her book is about interviews with multiple people affected by end-of-life issues, from physicians to patients to clergy. And the last book there is Finish Strong, going over the support for legalization of medical assistance in dying. In the middle, you'll find an incredibly timely set of references for you from the Center for Bioethics at the University of Minnesota. They did two webinars, one pro and one con, for the law that's currently being discussed in the Minnesota legislature. And if you go to their website there, you can find those links for you. Tonight, Dr. Thoman is going to walk us through the definitions of medical aid in dying. Also, she'll talk about the major arguments for and against legalizing it and the details of the pending Minnesota legislation. Before this, let's see how you in the audience feel about this issue. Do you think Minnesota should allow medical aid in dying for adults with terminal illness? Please mark the choice you would make right now before you learn more about the topic. 1 for yes, with reasonable parameters. 2 for no, I just can't agree to this. Or 3, it's a gray area. And we're long enough into Zoom that we all know how to do this now. Good, so almost 20% of people are unsure and everyone else is for this. Interesting. Sorry, I'm letting my dog out. Go. Okay, thank you. Can end that poll. For more details on the End-of-Life Options Act and medical aid in dying, let me introduce you to our guest speaker, Dr. Rebecca Thomann. As you can see from her bio, she trained as a family medicine physician, and she's used that medical expertise to work for decades in the sphere of prevention and public health policy. She's also a member of the Minneapolis League. Welcome, Dr. Thomann.
Thank you so much. And thanks to the League of Women Voters of St. Paul for sponsoring this conversation today. I'm going to go ahead and share my screen. Yeah, so tonight's topic is concurrence on medical aid in dying. And I'm going to explain what all those words mean, but starting with medical aid in dying, because I think that there's some confusion out there about what this is and some misunderstanding. So medical aid in dying is a very specific clinical medical practice in which a terminally ill adult who has sound decision-making capacity can ask for and then receive a prescription medication from their physician that they may self-administer for a peaceful death, if and when they choose. People will right away think of death with dignity in Oregon. And yes, in fact, that was the very first law of this kind, and most of the other laws have been modeled after the Oregon law. This came up with the Minneapolis League back in 2019. So there is legislation that's been introduced here in Minnesota, the Minnesota End-of-Life Option Act. It was actually first introduced in 2015 and has been introduced every year since then by Senator Chris Eaton, who is a nurse from Brooklyn Center, and Representative Mike Freiberg, who is a public health law attorney from Golden Valley. So when this topic came up for us, the League takes positions after doing studies, and we realized that a very comprehensive study had been done in 2016 by the League of Women Voters of Utah. So we dug out that study and used that as the basis for us to take up this issue as a program. We had a little committee and we got together and added updates between 2016 and 2019 because so much had changed in this area. And so we created a little addendum. And that's what we used, created a presentation, shared this with all of our members, and had some topics, discussion topics on this. And we also had learned in the process that at least four other leagues, state leagues, had also concurred with the report. So the League of Women Voters of Utah put out this report, and with it, accompanying it, they adopted a position, which I'll show you later in the presentation. So concurrence by these other states means that they agree and adopt that very same position as their own. And that's what we will be talking about. And that's what the Minneapolis League is bringing forward to the state council this year. We are asking for concurrence or agreement. So just a little bit more terminology also to clarify is that people think of death with dignity, which is in fact the name of the Oregon legislation. It's also the name of the legislation in Washington State and Maine. However, medical aid in dying is the practice that's defined in the statute. Other states with similar laws have given it other names. For example, California and Colorado both call it the End-of-Life Option Act, which is what the Minnesota bill is named after. Other states have other names. So they are sometimes used interchangeably, but they really are not the same thing. One is the name of a specific bill and one is the medical practice. So I'll be talking about this and referring to it as medical aid in dying. You'll also hear people refer to this as assisted suicide. I think that is older terminology that is going out of use in part because just by the statute, and I'll tell you more about how the statute says this isn't suicide. So legally, it is not, but also clinically, there are some very specific differences. So medical aid in dying is authorized in 10 states, the aqua colored states, which includes DC. And then the blue, dark blue states are where legislation has been introduced. And actually, there have been more bills introduced since we made this map, so it's a little out of date. So you can see that there is expanded interest in medical aid in dying. And just to put this in a little historical perspective, so the very first law in Oregon was passed in 1990. Actually, it was passed in 94, but was not enacted until 1997. And that was a ballot initiative. There were some legal challenges, and actually the Oregon legislature, the first time it passed, they rescinded it, and then it was passed again by an even larger margin. So the Oregon voters actually passed this twice before it went into effect in 1997. In 2009, Washington State became the second by ballot initiative. And between those, in that 10-year period, the issue actually went all the way to the Supreme Court. And it was Justice Sandra Day O'Connor who wrote the opinion saying that, in essence, there was nothing in the Constitution that either prohibited or protected this. And it was really an issue for the laboratory of the states. And at that point, this has gone back, and state by state, this issue has been taken up. In 2009, there was a court ruling in Montana that said that this was not prohibited, and so it is allowable, although they do not have a specific legislative bill there. Vermont was the first state to pass this through legislation in 2013, and then California in 2015, and that really was a tipping point. Many people may remember the story of Brittany Menard. She was a young woman from California who had a brain tumor. She and her entire family moved to Oregon to take advantage of the death with dignity law there. And after her death, her family moved back to California, and within a year they had passed the legislation there. And that really was a tipping point. Brittany was on the cover of People magazine, and her story was just got so much national attention. It really launched the next phase of this movement. So in 2016, the law was passed in Colorado by a ballot initiative. And I like to remind people that, remember who ran for president in 2016? We had two candidates. In Colorado that year, one of those candidates got 43% of the vote. The other got 44% of the vote. But the End-of-Life Options ballot initiative got 68% of the vote. It was the highest vote getter of anything on the ballot that year. And I just emphasize that to reiterate that this is really a bipartisan or nonpartisan issue. And I'll have some more survey data to show you. But if you talk to people across the country, regardless of their political views, they are supportive of this. Washington, D.C. then passed it in 2017 through its city council, Hawaii in 2018, and then in 2019, both Maine and New Jersey. And just last year, New Mexico became the 10th state. So about 22% of Americans currently reside in a jurisdiction where medical aid in dying is allowed. So I also wanted to put this in the context of end-of-life options and what are your end-of-life options? I'm sure many of you have created healthcare directives, and you know that pursuing life-sustaining treatment is probably the default, we would say. It's do everything, and typically that was what will happen unless you have a directive saying otherwise. So you are also completely allowed to refuse life-sustaining treatment, and you can also begin it and then discontinue it later. You can opt for comfort care only, which is hospice care, and that's a benefit, a Medicare benefit, that provides support from an interdisciplinary team of professionals who are helping the patient be comfortable, have a quality of life, and live out their final 6 months of life the best way they possibly can. VSED is an acronym that means voluntary stopping eating and drinking. And this is something that, for example, someone who is dying from cancer at the end of life and has done all the treatments and is really suffering and just decides they've had enough and they stop eating and drinking. And that is legal. You can get medical support to go through that. People typically will dehydrate in 7 to 10 days. After the first few days with the right medical support, it's not uncomfortable for the patient. They're kept comfortable. It's sometimes difficult, though, for families to go through that process. And then continuous deep sedation is typically something that is provided to patients who can no longer speak for themselves. So their agent, their healthcare agent, and their medical team will maybe say, the patient is clearly suffering, their difficulty breathing, they're agitated. And so they'll be given medication that will put them into a comatose state so that they are comfortable. Sometimes enough medication is needed that will actually suppress breathing, but often they're put into deep sedation. And then at that point, they may stop eating and drinking and again, dehydrate in 7 to 10 days. So medical aid in dying then is another option. You might think of it as an alternative to VSED for some people, and we'll talk more about exactly what this is. So I'm taking this information now based on what is in the Minnesota law, and it's based on the Oregon law. And the basic portions of this are the same in every law, although there are some differences. So in order to qualify for medical aid in dying, you must be an adult, at least age 18. You must reside in the state, be terminally ill with a 6-month or less prognosis, which we know is the same qualification for hospice. And you must be mentally sound. And by that, we mean able to make your own healthcare decisions, able to give informed consent, understand the consequences of what you're doing, have a memory that's intact, be free from coercion. So being in a place where you can actively participate and make your own decisions. And then finally, you must be able to self-administer, and that primarily means swallowing, although there are other mechanisms through the GI tract that may be used, but it is essentially through the GI tract. There are no injections. So this is not euthanasia, which is what we do to our pets at the end of life, right? We give them an injection to put them to sleep. Nobody injects anybody. Nobody does this to someone else. This is totally patient driven. So the individual has to go through the entire process at their own request. The process is also laid out in the law so that the person who's interested must first submit a written request, and there's a documented form, and must make an oral request to their provider, who then documents that in the chart. The physician will do a complete evaluation and assessment of the patient. Often these are physicians who are already familiar in caring for the patient, but to determine the eligibility in terms of prognosis and in terms of mental status. And then they must go through kind of a checklist of providing to be sure that the patient is receiving all the information and getting informed consent. So providing a full list of alternatives, being sure that the patient understands that they can rescind at any time, offer them a hospice referral. Hospice is the gold standard for end-of-life care, and it's something that we want everybody to take advantage of. However, it's not required in order to qualify for medical aid in dying. But any physician confronted with a request like this from a patient will immediately want that patient to be evaluated and refer them for hospice care. And then after the initial provider goes through that, they're referred to a second physician who goes through the same process again. And you'll see on my screen, I have physician/NP, and that is one of the differences in the Minnesota law. New Mexico was the first law that actually allowed nurse practitioners or advanced practice nurses to also participate as a provider. Every other state jurisdiction requires physicians only. And so Minnesota's law includes qualifying advanced practice nurses, and that's in part because they already have independent prescribing and practice authority in our state, and that was done originally to expand access to care, and so they are included as qualified providers in the Minnesota bill. So that's one difference from the Oregon bill. And then if either provider believes that there's any question about the patient's competence, they can call in a mental health referral, and that would be the final decision. So typically doctors, it's usually very clear when patients have they have capacity. You know, we get informed consent from patients every day, and it's often very clear when they don't have capacity. But when there are these gray regions, that's where a mental health assessment might be called for. So there's some other safeguards in the bill. The safeguards were, the first is really for protection of providers, that no health professional and no medical institution is required to participate. So they may opt out. Healthcare facilities and institutions and organizations may adopt their own policies as to whether they choose to participate. And then there is liability protection for health professionals who follow as long as they're following the process laid out in the law, they are protected from criminal and civil liability. And then this is the part that I was referring to earlier, which is a very specific clause that says actions taken in accordance with this bill are not, for any reason, suicide, assisted suicide, mercy killing, homicide, etc. And so that's really important because that is the legal definition and protection. So I often get questions from people like, oh, if I do this, will it nullify my life insurance policy? No, because this is not suicide. What goes on the death certificate is the underlying disease. Similarly to a patient who is in hospice care, for example, and stops eating and drinking or receives palliative sedation. The underlying disease is what's listed on the death certificate. So now I wanted to talk a little bit about the supplemental materials, and you can find all these things now on the League of Women Voters Minnesota Council website. So in addition to the Utah report study that you have, we created these supplemental data that I was just going to go through briefly, and that includes some updated year-end data reports. So all the states where medical aid in dying is authorized, the departments of health put out an annual report at the end of the year, which and they're all a little bit different about what information they contain. And Oregon's is the most robust and the most the longest. We have 25 years of data there. So I'm just going to talk about the Oregon report, but every year there's information that comes out of the reports. And I really recommend, if you want to do a deeper dive, that you go ahead and look at them. The newest report from Oregon just came out this month. The data I have that I'm going to present is actually a little older because I wanted to stick with what's in the supplemental material, which was created in 2020. So I'll be talking about the data from 2020. And then there's also been, since 2016, some changes in the medical associations and their positions on this, which we wanted to update. And then additionally, we have some specific Minnesota-specific survey information, and that again was from 2016. So that's all in the supplemental information. So the Oregon data shows, and again, this is from the report from 2020, which covers up through 2019, that for those 22 years that the bill had been enacted, a little under 3,000 individuals actually received a prescription, and a little under 2,000 ingested the medication. And so about 2 out of 3 actually utilized and ingested the medicine. And this is very similar in the reports from the other states. So when you look at the reports from Colorado, California, Vermont, Hawaii, it's very similar that about 2 out of 3 patients who receive the prescription actually ingest the medication. We don't know why. We can speculate as to why, but there really is not specific data on why. The diagnoses are also included in the report, and the most common diagnosis by far is cancer. So most patients who use this are in end stages of cancer. And the second most common are neurodegenerative disorders like ALS. And then the next group is heart and lung disease. And what's important to note about these is that these are the kinds of diseases that have a fairly predictable trajectory. So, some diseases people start to deteriorate, and that is a steady movement toward ultimate death. Other diseases, people may have an episode and bounce back, have an episode and bounce back. And so those are typically not utilizing medical aid in dying because the 6-month prognosis is less predictable. There's a much clearer path, and the prognosis is more reliable. 95% of the folks who used this in Oregon were enrolled in hospice at the time. And like I said, that's what we want to see, people enrolled in hospice. The numbers are not as high in other states, but they're all in the 60s and 70s. And the reason is Oregon has excellent hospice care. They're at the top in the entire country in terms of access to hospice care and appropriate use. So Oregon really does stand out in that area. And then I note this for a couple reasons, and again, it's similar in every state, is that the demographics show that this is really being utilized by mostly white, higher educated, insured individuals. And this is important to note because I think 25 years ago, when these laws were first coming into effect and being designed, there was concern, and you'll see that delineated in the Utah study. There was concern about how this would actually work. Would this be something that would be used against vulnerable groups like the elderly or minority groups or people with disabilities? And what we found now, 25 years forward, is that in fact, it's the opposite. The groups, those minority groups are much less likely to use medical aid in dying. And part of that has to do with the fact that no government insurance program will cover it. So it's not covered by Medicare. It's not covered by the federal portion of Medicaid. It's not covered by the VA, nor any federal employee insurance program. Some states like Oregon, and I believe Colorado, the state portion of Medicaid will cover it for some people, for those people. And then many private insurers cover it, some private insurers do not. So it really depends on your insurance status. And if you're only on Medicare, Medicare doesn't cover it, then you'd be faced with out-of-pocket expenses. So again, in 2019, 142 physicians that year wrote 370 prescriptions. So just kind of shows that it's becoming more integrated. It's not like there's one doctor or two doctors in the state who are writing all of these. It's anywhere from 1 to 10 prescriptions that a physician might write in a year. And there's been absolutely no abuse of the law that's been documented anywhere. There's been no physician discipline. There's been no legal action. In fact, the Disability Rights Oregon organization has not received a single complaint about the Death with Dignity Act in the entire 25 years. They have received complaints that because the law requires ingestion, that could be discriminatory against people with swallowing disabilities. So it's kind of, again, it's the opposite of what it was expected from decades ago. Again, I really encourage you, if you want to dig deeper, to go take a look at even just the most recent Oregon report. It's from the Oregon Health Department website. So update on the medical groups. And so historically, medical associations have been opposed to, they call it assisted suicide. However, those attitudes have been changing over the last couple decades, and medical groups are moving more to not opposing. And it's kind of a neutral stance where they are neither opposed nor in favor, but because their members are divided, they want to engage to be sure that laws are protecting patients and doctors, and they want to be sure that physicians who, whether they participate or don't, that's respected. And so moving to a neutral stance is becoming more common. The largest group to have done that is the American Academy of Family Physicians, and then the American Academy of Hospice and Palliative Medicine, and these are the doctors in caring for patients in hospice. The American Academy of Neurology, again, because they care for a lot of ALS patients, and the American Nurses Association. All of those groups in the last 4 years have moved to a neutral stance. And then even the American Medical Association took another look at its code of medical ethics and wrote an opinion determining that according to the code of medical ethics, doctors may practice and provide medical aid in dying without violating their ethical or professional obligations. So essentially they've said this is not, this is within the code of ethics. It's not outside of the code of ethics. And then 12 state medical societies have also moved to a neutral stance, including the Minnesota Medical Association. And then this is some surveys from 2016, Minnesota specific. Overall support was 73%, with Democrats, Independents, Republicans, all with majority support. Metro versus Greater Minnesota, again, majority support. And then even among religious groups, Christian was 52%, but when you pull Catholics out, that's actually one of the highest Christian groups within. 71% of Catholic support, and people who with someone with a disability in their household, also majority support there. So, this is my favorite, the State Fair. The State Fair, Sacred State Fair survey in 2016, and this was the actual question that was asked: when a mentally competent adult is dying from an incurable, irreversible medical condition that is expected to end the individual's life within 6 months, do you think the individual should be allowed to obtain from a physician a prescription for medication that may be self-administered to end that person's life? 68% yes, only 23% said no. So I wanted to go back, and I hope if you haven't had a chance, you will go back and read the Utah study in depth. I'm just going to touch on some of the pros and cons that they discussed that I think are worth digging into a little bit more. So on the pro side, it was felt that medical aid in dying was about autonomy and individuals being able to control their bodies, relieving suffering. It was not intentional. The intention is not to kill someone or end their life so much as it is to relieve suffering in an inevitable terminal a terminal condition. So the person is dying, and whether or not they receive medical aid in dying does not affect the outcome. They're going to die. However, it does change the index of suffering. And then the fact that there has been no abuse, and some of the concerns that had been raised were found to be untrue or didn't come to pass. On the con side, the discussion is a lot around being morally wrong or going against the Hippocratic Oath, saying that this is not something physicians should be allowed to do. Some argued that it's unnecessary because hospice care is now really good and can handle all discomfort without hastening death, and that maybe we just need more hospice care. And then also the slippery slope argument, which is kind of from, like I said, it's been for decades, it's been a concern that this would become a slippery slope. We'd start, moving to euthanasia, where we're injecting people, using it against people, especially the elderly, poor, people with disabilities, et cetera. So those are the arguments and concerns of those who oppose. So after going through that, so we went through the report, we went through our addendum information and talked a little bit about whether or not this aligns with the League of Women Voters' values, like why should we care about this? We do care about educating about issues of the day, but also people felt that it was about, individual autonomy over one's body, and that was a particularly important issue for women, because historically women have not always had control over their bodies. And so individual privacy as another issue, religious freedom, the feeling that people have different views about this. And currently, in the state, this is criminalized. Medical aid in dying is a crime. Physicians anybody who would participate could be charged with a crime. And so religious freedom would say, well, not all religions agree that this should be a crime. So, and then equal access to healthcare being, 10 states provide this or allow this already, and people it shouldn't matter where your zip code is to be able to access something. And then just to remind that this is a state issue. It's not a federal issue. So it's unlikely the League of Women Voters US would have a position on this because it's not something that happens at the federal level. It's a state by state issue. And so the state league is the appropriate place to take this up. And so after we had, so here's the actual language. So this is what the Utah position says. And this is what we then, Minneapolis League, concurred with. I'll leave it there and let you read it yourself. So we voted to concur on this, and then the next step for us, of course, would be to take it to our sister leagues and bring it to the state league for consideration, because we can support it, but because it's a state issue, it really, the League of Women Voters Minnesota needs to take a position before any local league can go out and lobby for it as a local league. So we've moved for the concurrence. We took it to the 2020 convention, and guess what? Remember 2020? It was canceled. So there was no meeting that year. We did put the information out to some of our other sister leagues, and a couple of them actually did take us up on hearing about it. Golden Valley, I think, was one, and Wayzata Plymouth, and they had also concurred. But so we tried to spread the word a little bit. The 2020 meeting was canceled, so we took it to the convention in 2021, and we won, but we lost. So we got a majority vote support, 58%, but we needed 60% to prevail. So the vote for concurrence failed, and that's why we're coming back this year. And I would love to hear from any of your members who were delegates to the convention last year. But my take on it is that the primary concern was that not enough league delegates had heard about this or knew enough about it in advance to feel comfortable voting. We did everything we could to try to spread the word. And this year, I think this past year, after this experience, we formed a little committee, and we had various, about 6 or 8 people from different leagues. We formed a committee, and we made it a particular effort to go out and share this information with other leagues and let them know what's in the law, what is in the position. And we've been doing a series of these forums just like this one. And then we will reintroduce a motion for concurrence at the Minnesota Council meeting on April 30th. And the motion will be, do we concur with the Utah position as you saw it written, which means the League of Women Voters of Minnesota would adopt that position. So just put Minnesota where you see Utah. So your delegates who go on April 30th will be there. I think there are 2 issues. The other one is gun violence. There are 2 issues that are going to be up for a vote. And so that's why we're here, so that your delegates and your league can know more about this and go into that informed for the annual council meeting. So I'm going to stop sharing my screen, and we can go to questions and comments.
Thank you, Dr. Thoman. Fantastic. Yeah, we do have a couple of questions. We're starting off with a question that is interesting to me, and the question is about some of the awful deaths that we've seen inflicted by euthanasia in state-sponsored, in the prisons for death row inmates. And are there any concerns about very uncomfortable, awkward administration when the patient has to drink the medicines? Have you heard any stories about that? Any thoughts on that?
Well, that's what's happening with patients who are receiving the death penalty is not happening within the medical system. So that's a big part of this. This is going to be a medical practice that has been tried, and we know it works, and it's with all the safeguards of a medical system. So the patient is in hospice care. What happens with I really don't know much about how they euthanize patients, but it is not anything like this process. This is total, and I could talk more about it, but it's a medication that comes in a powder form. It's a 4-drug combination, and the patient drinks that in a couple minutes. They go to sleep usually within about 10 minutes, and then slowly they stop breathing. And so it's a very peaceful and gentle process, and they've been doing it now around our country for 20 years.
Yeah. And then quite a few questions about Alzheimer's and dementia, and
Yeah.
clearly understanding that none of the states allow for people who can't make their own decisions, who can't decide that they want to end their life, but clearly have a remarkably horrible quality of life. Can you
Right.
talk at all about what you've heard from the different states or the different legislatures about including people with tremendously bad qualities of life, but who are not competent to sign something like this?
Yeah, this comes up at every discussion, and people who are in an advanced enough state of dementia that they can no longer make their own healthcare decisions would not qualify. So this is not something you can put in your advance directive, because remember, an advance directive goes into effect when you can no longer speak for yourself. So, and you must be able to speak for yourself to qualify for medical aid and dying. So what people can do is prepare a specific portion of your advance directive that deals with dementia. And so there are dementia specific directives that will help guide you through the level of care that you might want based on the advanced level of your disease. So as Alzheimer's progresses, what level of care do you want to have? And you can even ask for stopping all eating and drinking at an advanced stage of dementia. It gets harder to do as for the individual patient, because you'd be depending on others to do that for you. But there are patients who in early stages of dementia will decide to stop eating and drinking. We have a person actually here in Minnesota who was in the newspaper recently. She has early Alzheimer's. She knows what's coming, and she's going to find when she's at the right time, she's going to stop eating and drinking. And that's legal. And with good supportive medical care, it's not necessarily uncomfortable. It's hard to get through without support. And I think it can be hard for families,
Mhm.
but that is the option that someone has with dementia.
And when you say legal, do you mean that the death is not marked as a suicide, that the survivors can still get benefits, that it's, what do you mean legal when a person takes this combination of four medicines and drinks this?
Well, that is the act of medical aid and dying. If the legislation is passed, then if you're going through the process as it's laid out in the law, that's legal. So that is the legal process. What happens with, is this going back to executions? Because that's totally outside the medical system.
No,
Okay,
thinking, is it legal? Do you mean legal for the docs or legal for the patient? Do
both,
you know what I mean?
both. Because the concern is, and right now it's not legal in Minnesota. It's a
Right.
crime. It's considered assisting a suicide, whether it's done by a physician or if they wrote a prescription, or if a family member helped someone who wanted to be done at the end of life, that all of that is considered a crime. So until we have something that lays out what medical procedure is acceptable under the law, everything is considered a criminal act that would be intentionally helping a person who has capacity
Mhm.
to take a medication to end their life.
And then one question was about what the feel is at the Capitol now for lobbying. When groups want to lobby about these bills and laws that are being discussed, can you go in person now? Have you been able to log on to Zoom conference calls, or what's the feel right now at the Minnesota Capitol, and how do people get involved that way?
Well, everything that you can do in person, you can do remotely, and it's a lot easier and faster. And lawmakers are doing all kinds of remote. In fact, Compassion and Choices is having a week at the Capitol on this at the end of April. So there are opportunities to engage as individuals, because the league doesn't have a position. You can't go out and say I'm a leaguer, but as an individual, you certainly can. Um, the problem with what's happening at the Capitol is the same problem that I think a lot of important issues are facing, which is it's hard to get people's attention. There's so much else that's really pressing. There are so many needs. And The voices who are advocating for medical aid in dying are often family members of people who have recently died and suffered, terminally ill patients. So until we get more of a grassroots demand for this, I think it's easier for legislators not to think about. Nobody wants to talk about death anyway. So meeting with lawmakers and telling them about it, why this is important, I think that's what's going to move the dial on this for individuals to get involved. And if the league does pass this, does adopt this as a position, that would be a good position. You'd be well set up to put a question about this to the candidates. So that would be a great opportunity to start having candidates thinking about it before the election.
And then someone wondered if you knew specifically what drugs were involved in the concoction that the person drinks, and if you can talk to us about what the mechanism is. What happens to the body when a person takes these meds?
It's a 4-drug combination, and there have been some tweaks to the drug. So it's digoxin, which slows the heart, Valium, which is a sedative, morphine, which is a painkiller, and then amitriptyline. Phenobarbital is also a sedative, which is sometimes used. And amitriptyline, I'm not sure, but it seems to potentiate the action of the other drugs and make them work more quickly. So you're essentially your heart rate is slowed and your breathing is suppressed at the central level, and you lose consciousness, go to sleep, and your heart stops and you stop breathing. And it's a very gentle process. It's like dying in your sleep.
And I'm reading another question. Does the individual who chooses this option arrange for a provider to be present at the time of ingesting the medicine? And then does someone have to pronounce the person? What happens? Does a doctor have to be there? I think the answer to that is definitely no.
It's individual. It's up to the individual patient if they want somebody to be there. Death doulas are taking an increasing role in this kind of thing. Nurses may be at the bedside, family members. I think that family members definitely want to be educated by the nurses and physicians so that they're clear about what they're doing. Pharmacists are also sometimes involved in helping people understand how to prepare and dispense the medication, but there's not a requirement for that.
There was a question. I'm not sure I'm following, but you'd mentioned body control, self-autonomous control as being part of the reason that the Minneapolis League supported this or concurred with the Utah position. And that brought up the issue of controlling your body, especially in some southern states where now I think the listener is thinking about Texas and the abortion law. Is there any stance? They ask, what is the Minnesota League of Women Voters position on this? Um, I'm not sure if they're asking what the position is about abortion, or I think I can already answer that the Minnesota League doesn't have yet a position on end of life issues, because that's what you're bringing to the council in April.
You'd have to go back. I'm not sure what the position says about human rights, but the US League does have a position on abortion related to physical control of your body. I can't say what it is, but definitely the US League has a position.
Yeah, and there, for people who are listening, you can go to the U.S. League of Women Voters website or the Minnesota State League of Women Voters website, and they will have positions. So the league will spend sometimes years looking things up, documenting facts, doing their own studies, querying their members, and then come up with a position on different things. And so you can find those position statements. And then we do have someone who's just giving you a comment, Dr. Thoman. Having cared for in hospice a patient with severe cancer where his bones were disintegrating and causing excruciating pain and wanted to die, I support this effort. And I have to say, as an oncologist, there are certain situations that we control the symptoms really well. And I haven't found a high need for medical assistance in dying. I hadn't had a lot of questions about it. But there, in every doctor's practice, are situations where people have just unmanageable, excruciating symptoms. And you're nodding your head. I know there are other doctors in the viewing audience. I know there are nurses. It's hard to imagine if you've never had anything medical happen to you, and that's I think part of what you're trying to educate us about is that sometimes things happen we're not expecting. We don't plan for this to happen to our loved one or ourselves, and trying to have this as an option certainly doesn't mean that a person has to do this.
Oh, absolutely not. And in fact, you can see from the very small numbers of people who actually use this. However, there is sort of a palliative effect for people just knowing that this is an option. Sometimes just, we had someone was telling me a case where the patient was so distraught and upset and depressed and wanted this option. And when she learned she actually could get it, she felt better. I mean, she was happier for the rest of her remaining days and weeks because it was an option. So it gives people a sense of control. When they're really out of control from disease, that can be something to hang on to, whether or not they choose to use this. And I've seen ovarian cancer patients are common people that we see who want this option. They're in support groups and they see what others go through and they just say, I don't want to go through that. I don't want to be put into a comatose state. I don't want to be sedated. I want to just go out on my own terms. So part of it also is sort of personality more, and not necessarily, because some people will go through and suffer through pain and want to live and hang on to that, and that's fine for them, and others don't. So it's kind of individual. But it's always suffering or anticipated suffering in someone who's dying.
And then an audience member had some personal frustrations with personal experience in a hospice situation, asking why should there even have such an issue when an institution like this is supposed to keep the person comfortable. And I don't know if you want to kind of tackle how there are times when our medical support just can't keep a person comfortable, whether it's terrible agitation, terrible shortness of breath. Pain is something that I feel like we've gotten so much better at, but sometimes there's still intractable pain. And a lot of times you get caught in a catch-22 because the person doesn't want an IV, they want to be home, and yet the best medication would be intravenous, and they're at home and they don't want to have their husband or their dad try and give IV medicines. It's scary to the caregivers. I don't know. Can you discuss that at all? Like how we fail sometimes
And
at
I
keeping
don't know
people
if it's
safe and comfortable?
I don't know if it's how we fail. I think there are situations where we fail, but I think there are also some diseases and experiences of diseases that that we may say, oh, that's okay, but the person experiencing it doesn't want to live that like that. And for them, it's undignified. For them, it's they don't want to be forced to be kept in the state. And so examples are things like there are oral cancers where the smell emanating from a mouth cancer is so horrendous that the patient they don't want anybody to come into the room because the odor is so foul, and that destroys their quality of life, and they don't want to go on that way. There have been fistulas where women are draining fecal matter constantly through their vagina, and they don't want to live like that. So, and how there's not much we can do for that. Bowel obstructions with vomiting. I mean, it's just, it's the individual's person's kind of sense that I don't want to do this. I'm dying. I want this to be over with. And so it may not necessarily be pain, but it may be the kind of quality of life that for them is unacceptable, and they just don't want to do it. And they're going to die. They know they're dying. So why are we not allowing them to end it on their own terms? And for some cancer patients, they say, I fought this disease and I'm not going to let it take me out. I'm going to go out on my own terms. So I've heard that kind of too, which is I'm taking back control from the cancer.
Yeah,
So I've heard a lot of different things.
I think this person had particularly bad experience with institutional hospice, and just it didn't seem like the hospice care was willing to aggressively treat pain because they thought it would, quote, kill them. And we still do have some remnants of that in our medical system. I mean, my family, my grandmother died at age 50 of metastatic breast cancer, and this was in the early 60s. And uh, medical management was firmly in the you can't give people narcotics, they might get addicted. You have to
Right.
wait. The nurses would literally point to the clock and say it's not time for your med. And my mom just remembers she was in
Yeah.
agony. So
And
these
that
things
does,
that we have gotten much, much better.
we have gotten better, but it is important also to know that um, religious institutions in particular may have restrictions on what they are willing to and or allowed to do. So that's really important. And the individual nurse or physician, they may be acting by their own values. So it's really important that you know who your care team is and you know what the policies of the institutions are. Because you're right, there are people who say, I won't do it, it might kill them. And it's like, give them the pain medication. So yeah,
And
it's
we
very
should
real.
make a plea for everyone to do their advanced directives and have living wills. And if nothing else, just talk with your loved ones about what your wishes would be. You think now. Everything changes when we get sick. I mean, things can change, but at least have that conversation.
Right.
And now that we've cheered everyone up with talk of, we're just going to move right on from the bowel stuff and the smells to our next slide. And we're going to thank you so much, Dr. Thoman, for your great talk.
Thank you.
Let's try the survey one more time before we end, now that you've had a little bit more information. One, yes, I think this is reasonable law. Two, I still just cannot condone this. Three, I'm still not sure. See what you think. Yeah, it's looking like a lot of people who had been undecided maybe are not so undecided anymore. Yeah. So far about 100%. A couple people haven't done, but thank you. So, real quickly, next month's topic is an update on the firearms study. We hope you can join us on Tuesday, April 26th. Again, many, many thanks to Dr. Rebecca Thomann for her presentation tonight. Thanks also to the program committee for their work behind the scenes of this program, the Roseville area and White Bear Lake area leagues, along with SPNN. And thank you so much to our audience for joining us tonight, for your excellent questions, and for taking your precious time to ponder this issue. We'd love for you to answer the survey that will pop up after we finish here tonight, because your feedback helps us design future programs. So thank you so much and have a wonderful night.